everybody, and welcome to the Immunity Canada's Immunodeficiency 101 webinar today. I'm Whitney Ayub. I am the Executive Director with Immunity Canada, for those of you who don't know me. This is one of our first webinars on this topic. We have our first of our spring series of webinars. And before we get started and I pass over to our presenter, I'm just going to do a few housekeeping notes and then we'll pass over. So first, I'd like to welcome everybody and do our land acknowledgement, our virtual land acknowledgement. So Immunity Canada acknowledges that from coast to coast, we are all guests on the ancestral territory of the Inuit, Métis, and First Nations people. And all of you joining us and all of our members are encouraged to consider your own position and relationship to the land where you find yourself today. And as part of improving our understanding of local Indigenous people and their cultures, today, we ask that you take a minute and think about that in the spirit of reconciliation as we work and play on these lands. And for those of you who may be joining us today for the first time, and also for those of our members who this might not be the first time, we'd like to start by looking at and reminding ourselves who we are as an organization and why we're doing these types of events. Immunity Canada, our mission is to empower Canadians who are impacted by immune deficiency disorders to live well through education, support, advocacy, community building, and research, which is why we host events similar to this. And our vision is that all Canadians with immune deficiency disorders have access to the resources they need to thrive. Again, that's why we do events like this. And we hope to be able to empower through those resources. And those are our values, our community, equity, inclusiveness, empowerment, excellence, and innovation. We do encourage you all who are joining us to take part and participate today. Obviously, you don't have to, but we hope you do. We will have a Q&A at the end of the presentation. We will have plenty of time to ask questions, and we do encourage that. Today, there is a Q&A function in the Zoom and a chat function. So please type your questions in for Dr. Kim. And if you have any technical issues and you find yourself unable to do so, or you're not really sure how, you can email us. We will be checking the info email as well to answer questions. And please note that the session is being recorded and it will be sent out, but only myself and Dr. Kim will be seen on the recording. But questions from the chat that you type in may be read aloud. So if you have anything that you may not want to ask or you're embarrassed to ask, that might not want to be read. That's okay. You don't need to share. You can also mention that as well in the info box. I will make a disclaimer that we use with all of our events. Immunity Canada is not a medical organization, and our events offer a different array of speakers. Today, we have one of our medical directors, but these views and opinions by our guest speakers don't necessarily reflect the views and opinions of Immunity Canada. So please do not also substitute any of the advice from your physician or other qualified health providers regarding your medical condition for those that are in our events. Also, please note that Dr. Kim, who is with us today, is not able to give personal medical advice. So please, when you do put a question in, note that she will not be able to respond to personal diagnosis or medical and share medical opinions or personal medical advice. I would like to welcome our speaker, Dr. V. Kim. She is not only one of Canada's Medical and Science Advisory medical directors, but she is also a clinical immunologist and allergist at the Hospital for Sick Children in Toronto. She's also an associate professor at the University of Toronto, where she is director of postgraduate medical education for pediatric clinical immunology and allergy. Her area of focus include inborn errors of immunity and gene therapy for inborn errors of immunity. She's also the chair of the Severe Combined Immune Deficiency Disease-Specific Working Group for Newborn Screening Ontario. Among other things, she's also just pretty great, and we're really excited to have her here. So I will stop sharing my screen and hand it over to Dr. Kim to present.
Thank you so much, Whitney, and thank you for allowing me this opportunity to come and speak to everyone here about immune deficiencies. So over the next hour or so, we'll be talking about an introduction to immune deficiencies. So I'll describe what inborn errors of immunity, or what some people also refer to as primary immune deficiencies, are. We'll discuss how these are classified, and we'll also review the components of the immune system. And that way you can see how problems in components of certain parts of the immune system can lead to immunodeficiency and, for example, susceptibility to infection. So inborn errors of immunity, or sometimes I'll write this as IEI, are inherited problems in the immune system in either the development of certain parts of the immune system or the function of certain parts of the immune system that can lead to increased susceptibility to infections. And this can be more frequent or severe common infections, or it can be susceptibility or an increased risk of developing unusual or atypical infections. But the immune system does more than just fight against infections. It also plays an important role in controlling or policing itself. So when the immune system doesn't work very well, we have what's called immune dysregulation. And that means that, again, it doesn't do a great job of policing itself. And so this can lead to cells that misbehave, leading to autoimmunity, or cells that will grow abnormally that can lead to malignancy. And so you may have seen, again, IEI, or inborn errors of immunity, and primary immune deficiency, or PID, being tossed around. The older literature often referred to these groups of conditions as primary immune deficiency. And historically, again, we focused a lot on the infection presentation. But there are, again, increasing appreciation, as I mentioned here, that problems in the immune system can lead to more than infections. And so the term inborn errors of immunity was taken to reflect more than that susceptibility to infection, that it can lead to, again, this immune dysregulation. And so there's this concept of this spectrum of problems with the immune system, where some on one end of the spectrum can have a really increased risk of severe and unusual infections. And then on the other end of the spectrum, you may have less risk of infection, but more issues with immune dysregulation that leads to autoimmune problems or lots of inflammation. But many of the immune deficiency problems actually are along the spectrum, where you can often have a combination of both the susceptibility to infection as well as this increased risk of inflammation or autoimmunity. And what's been really amazing over the past number of years is that we've almost seen like an explosion of the discovery of underlying genes that can cause problems in the immune system. So you can see, again, back in the 80s and 90s, which kind of feels like a long time ago, but actually wasn't that long ago, we really had maybe a handful of genes that were known. And at the last count, there were over 500 genes that have been associated with problems in the immune system, leading to inborn errors of immunity. And so even though these are collections of rare diseases, it's now estimated that maybe about 1 in 1,200 people worldwide are living with an inborn error of immunity. When we talk about the classification of inborn errors of immunity, it's really to help us visualize or identify what parts of the immune system might not be working very well, and to group conditions with similar problems in the immune system together. These classifications, again, can change over time, and I'm just going to provide a broad overview because, again, there are much more specific classifications. Broadly, we can divide inborn errors of immunity into problems of the adaptive immune system, and I'll talk about that a little bit later on in the slide, what adaptive immunity means. But generally, adaptive immune system problems comprise of problems with T cells, or problems with B cells, or problems with both. Whenever there's a problem with T cells, we tend to classify that as combined immune deficiency. And when it's a problem of mainly B cells, we would call that predominantly antibody deficiency. Next big grouping would be disorders of the innate immune system. And again, I'll talk a little bit more about what that means. But this can include problems with phagocytic type cells or phagocytes, other defects in innate immunity, and problems with the complement system. And then I kind of group the other ones in other basket or miscellaneous basket. And this can include problems with immune dysregulation. Again, so these predominantly manifestations, autoinflammatory diseases, bone marrow failure syndromes that again can lead to low numbers of immune cells, and phenocopies of inborn errors of immunity, which is a little bit different in terms of not identifying an underlying genetic change in your what's called germline genes, but sometimes some patients can develop, for example, autoantibodies against certain proteins in the immune system that can lead to problems as well. When we talk about the distribution or how common certain types of immune deficiencies are within the whole group of immune deficiencies, the most common groupings are those antibody deficiencies. Following that are the combined or the immune deficiencies that involve your T cells. And then following that would be immune deficiencies involving phagocytic defects. The other types of immune deficiencies are not as common, but this doesn't mean they're any less important. It just reflects, again, the distribution of what's been diagnosed so far. I suspect, again, as we get better with our genetic testing and with other ways to diagnose immune deficiencies, we may see a shift a little bit in the proportions of these categories. I also want to highlight that typically most people, when they think of primary immunodeficiencies, they tend to think of this as a disorder of childhood or a diagnosis that's predominantly made in childhood. But we can see here, which was a survey that was done on over 1,000 patients with diagnosed primary immune deficiencies, the majority of patients were diagnosed as adults, with maybe, I think it was about 50 something out of those over 1,000 patients who were diagnosed before the age of 18 years. Now, it's not to say that immune deficiencies cannot present in childhood, and I think there's a number of factors contributing to that. One is we know that there's often a delay between the onset of symptoms until when someone is finally diagnosed with an immunodeficiency. And depending on the immune deficiency and how the initial symptoms present, often that delay can be many years. So in this graph, also from the same survey, the time to diagnosis was on average about 25 years, which unfortunately is too long. I'm hoping, and we do think that this is happening as well, with improved awareness and improved diagnostic, and with increasing specialists who have experience in clinical immunology, we're hoping that this time to diagnose is shortens. But I also want to highlight too that there are many immune deficiencies or inborn errors of immunity that can present later in childhood or in adulthood as well. And then we always say that whenever you're thinking about a primary immune deficiency, and we say primary to mean that this is something that's inherent in one's immune system, where there's something inherent in their cells or their protein that's not working well, we always need to make sure we're not missing another cause for the immune deficiency or for the infection. So this is what we would call a secondary cause. So for example, medications that affect the immune system can be a secondary cause of immunodeficiencies. A common one might be systemic steroids, for example, or chemotherapy. But we also know that there are other secondary causes like chronic infections, if there are anatomic or structural changes. Sometimes malignancies can cause a secondary immune deficiency if there's a lot of protein loss or other reasons as well. So, as clinicians, often when we're assessing someone for that possibility of primary immune deficiency, we want to make sure that we're not missing a primary cause. Now, let's run through a bit of an intro to the immune system, which can help you to understand where some things might go wrong or not work very well, and how that kind of translates to some of the manifestations that we see. So, the immune system is a collection of cells and proteins that function to protect the body from infection, but also to protect the body from damage and to survey itself. It's not like the heart or the kidneys where it's like one organ. This is really a lot of cells that travel throughout the body to different areas of the body, as well as different organs that may have collections of immune cells. So the primary ones that I do want to point out first is the bone marrow. So that's the inner part of the long bones. And that really is the birthplace of blood cells. So that's where those primitive stem cells, so those cells that can become almost any kind of blood cells, that's where they generally will reside. And that's the place where the immune cells will start their development in the bone marrow. And then they can travel to other parts of the body through either the bloodstream or through some specialized vessels, all of these little lines here, which we call the lymphatic system. And some of these immune cells will travel to the thymus, which sits right above the heart, located in the upper chest, where they develop and they become T cells. So we call them T cells because they develop in the T for thymus. And then there's also, again, many other places where you can find the immune cells collecting. So again, they can be in the lymphatics, they can be in the lymph nodes, which are represented by these blue areas. And the lymph nodes really are these collections of the T cells and the B cells that meet and they communicate with each other and tell each other what's going on and what we should do about it. We also have, again, tonsils where immune cells can collect. We've got the spleen where immune cells can collect. And the spleen can also filter blood and also provide that site for communication as well. We'll talk a little bit more about the individual cells. So again, this here represents the bone marrow. So again, the inner part of the long bones. And we have here the hematopoietic stem cell, or HSC. And this is considered the mother of all cells. So this cell has the potential to become almost any other type of blood cell. And immune cells are a type of blood cells, and they're part of what we would call white blood cells. Hematopoietic stem cells can also become red blood cells, which carry hemoglobin, and they can also become platelets too, for example. So again, these stem cells can become lots of different types of immune cells. One to notice would be neutrophils, which can also be called polymorph nuclear cells, or PMN cells. And they're a type of white blood cell that's part of the innate immune system. And they primarily function to eat or ingest microorganisms and then kill them. And that process is what we call phagocytosis. Phago is kind of like eating the cells. And these are usually the first type of cells that come to sites of infections. The other cells I want to point out are the T cells. So again, these are type of lymphocytes. So sometimes T cells are called T lymphocytes, and they will primarily mature into two broad types of T cells. We have your CD8, or what's called cytotoxic T cells, And we have your CD4, or what's called helper T cells. And again, T cells are called T cells because they mature in the thymus. We also have B cells, sometimes called B lymphocytes, because again, they're a type of lymphocyte. And B cells will mature in the bone marrow. So we say B for bone marrow. So they stay in the bone marrow and they mature and become memory B cells or plasma B cells. And B cells are primarily the machines that will create antibodies or immunoglobulins. So I talked a little bit about innate and adaptive immunity. The immune system function is broadly divided into innate immunity as well as adaptive immunity. The innate immunity are those responses that are pre-programmed since birth. So these are the responses that everyone has at birth. They're kind of preset, and there's no additional training needed for the immune system to be able to do that part of the job. The nice thing about the innate immune system is that because it's pre-programmed, it can respond quickly when it detects an organism or a foreign invader coming in. So this is often responsible for providing that early line of defense against infections. And the innate immunity can include more than just what we talked about in terms of the neutrophils. So some other components of the innate immune system will include physical barriers. So your skin, which is a really great barrier. And we know that, again, for example, if you get a cut on your skin, it increases your risk of having an infection where the cut was, because, again, there's been a breakdown in that kind of barrier. So skin and mucosal surfaces are part of that innate immune system. And these mucosal surfaces can secrete factors that can help to fight against microorganisms. We've talked about the neutrophils, which are part of the innate immune system. And then there's also the complement system, which is also considered part of the innate immune system. And then on the other side here, we have adaptive immunity. And adaptive immunity primarily involves the T cells and the B cells. The adaptive immune system is not as fast as the innate immune system, and it needs training. So it often will develop and refine itself through life as the immune system is exposed to different organisms. It learns from that and can adjust itself so that the next time it encounters that organism, it can respond better and with more specificity compared to the innate immune system. But because it needs training, because it needs to see that organism and teach itself and refine itself to be able to respond better, it does take longer for it to kick in compared to the innate immune system. However, the benefit is that it can respond to many more different types of organisms, and it can be more specific, and it can lead to long-lasting immune memory. So it can remember if it's encountered this type of bug years ago and create a better response to it. And this is the concept, for example, for providing immunizations, is so that we can allow that adaptive immunity, like the T cells and the B cells, to create a response, to prepare itself so that when it encounters that bug that you were vaccinating with, that it will be prepared to fight that infection better compared to someone who has not seen that bug or not previously been vaccinated to that particular bug in the past. So this graph here illustrates the timeline from minutes to years of how quickly the innate immune system can kick in, again, usually within minutes to hours, compared to the adaptive immunity, which is more in the time of days to weeks. However, with repeated exposures to the same bug or trigger, the adaptive immune system can respond more quickly and faster. And again, this is one of the concepts why we provide vaccinations to help prime that part of the immune system so that we can respond faster and better. Let's talk about some of the specific components of the immune system, and then we'll talk about how, again, problems can lead to certain types of immunodeficiencies. So again, I mentioned neutrophils are a type of white blood cell that are part of the innate immunity. Again, they're also called PMNs or granulocytes because they have these little dots and granules inside. And these, again, typically will be the first immune cells to come to sites of infection, usually within minutes. Their major role in fighting infection is to ingest the bacteria or fungi and kill them. And we call that phagocytosis. They can also discharge some of those granules or those cell contents that can also lead to destruction of the organism and recruitment of other immune cells. So the neutrophils, when they get to the site of infection and cause more of this inflammation, this can lead to the formation of pus. So pus that you generally see sites of infection, for example, tend to be those neutrophils doing their job. When you have problems with neutrophils, we generally would call these phagocytic defects because, again, neutrophils are phagocytes. So phagocytic defects can be because of problems with normal development of neutrophils or with how they can function. And because neutrophils play a big role in fighting off bacterial and fungal infections by eating them, when you have problems with your neutrophils, you tend to have increased risk and rate of bacterial and fungal infections. So some examples include chronic granulomatous disease, which is a problem with the function, a certain type of function of neutrophils. Or you can have leukocyte adhesion defect or deficiency, which is a problem of neutrophils getting to the sites of infection, or other examples include GATA2 deficiency. The complement system are a group of proteins that help to fight or defend against infection. So again, the complement system is part of the innate immunity. They're called complement because they enhance or complement the immune system. So it's fascinating how things are named, right? Most of the complement proteins are produced in the liver, and they have multiple functions. So again, they can help to defend against bacterial infections. They can activate an inflammatory response. They can tag organisms and mark them for destruction. And they also help to clear organisms that are foreign or debris or products of inflammation and injury. This image here is just to illustrate the complicated nature of the complement system and that there are various proteins and pathways involved. And many of them, again, lead to what's called this membrane attack complex, which some people refer to as MAC attack, where this can, again, help to puncture holes in the wall of the organism, which can lead to, again, its destruction or death as well. So when you're missing certain complement components, so if you're missing certain proteins along that complement cascade, that can lead to immune deficiency as well. Depending on which complement component is missing, you can have susceptibility to infections, particularly pneumococcal, meningococcal, or encapsulated bacteria. So again, meningococcal infections tend to manifest as meningitis, for example, but you can also have severe pneumococcal respiratory infections or invasive infections. And then some complement components can also lead to a rheumatologic manifestation. So for example, having autoimmunity that looks similar to lupus. The B cells are part of the adaptive immune system. So again, we sometimes call them B lymphocytes or B cells because they develop in the bone marrow. And these are cells that, again, when they encounter foreign organisms or germs, they mature into plasma cells or memory B cells. Plasma cells are mature cells that create antibodies. And the antibodies are these immunoglobulins. And there's different classes of immunoglobulins. So we have IgG, IgA, IgD, and IgE, for example. And here we have an image or a representation of what an immune globulin typically looks like. So it's typically drawn looking kind of like a Y. And at the top here is where the antibody will be able to recognize certain what we call antigens or parts of organisms. And the top of those antibodies tend to be very specific. So you can almost think of it like a lock and key. It's very specific to match a particular shape or a particular antigen. So one antibody that a B cell, an individual B cell will produce one type of antibody that recognizes a particular type of part of an organism. But you've got lots of different B cells that in the whole repertoire of your immune system, with each one creating a different antibody, you've got lots of different antibodies, each one recognizing a very specific shape or part of an organism. So these antibodies are really amazing in terms of being these very specialized and specific proteins that recognize different parts and help to activate or play a role in protection against infection. So these antibodies can do something that's called neutralization. So for example, some viruses need to attach to certain cells of the body before they can cause an infection. And if these antibodies, so these Y-like things that attach to the virus, they can block the virus from being able to attach to the body of the cell, and that way preventing that virus from interfering or causing infection. Similarly, for some toxins that are produced by some bacteria, it can do something similar where it attaches to the toxin and prevents that toxin from going on and causing more issues. Antibodies can also do something that's called opsonization. So again, like tagging the bacteria. So you have, again, the bacteria here, you have your Y-looking antibody, and it can attach to the bacteria and mark it so that neutrophils or other cells that do phagocytosis, like macrophages, can more easily eat up these components and kill the bacteria. And then antibodies can also help to activate that complement system. So again, these systems will talk to each other and help to amplify each other. And then the complement system can come in and again, at the end, create that MAC complex or that membrane attacks complex, which creates a hole in the wall of the bacteria, and that can cause the bacteria to die as well. So when you have problems making good antibodies, that generally will lead to an antibody deficiency. And so, as we saw, antibodies are really important in terms of fighting off bacterial and viral infections. And so, when you have a defect in antibody production, you generally will have an increased risk of bacterial and viral infections. And these infections can be almost anywhere, although very commonly we can see them as lung infections. So, for example, pneumonias, ear infections like an otitis media, sinus infections like sinus, but you can also see it as blood infections, skin infections, bone infections, etc. Some examples of antibody deficiencies include X-linked A-gamma globulinemia, where the problem is you don't make B cells. And as I mentioned, B cells are really important for creating those antibodies. Or another common antibody deficiency is CVI, common variable immune deficiency. And then we have our T cells. So T cells or T lymphocytes are also part of the adaptive immune system. And they're called T cells again because they develop in the thymus. The two big groups of T cells are your helper T cells. And so these are generally what we call CD4 positive T cells. And then you have your cytotoxic T cells, which are your CD8 positive T cells. Your helper cells do just that. They help other immune cells to do their job. So they help the B cells to create antibodies, and they can help recruit other cells to come and help fight off. So they're predominantly important when it comes to fighting off intracellular bugs, so bugs that like to go inside cells, parasites, and extracellular bacteria and fungi. But CD4 helper cells have also been implicated in autoimmunity and atopy. The cytotoxic T cells are your CD8 positive T cells, and what we say are cytotoxic, so they can kill cells that are infected with intracellular pathogens, such as some viruses, certain mycobacteria, or other bacteria. But they can also kill cells that look abnormal, or again, that look like they could be cancer cells or tumor type of cells. So when you have problems in your T cells, we would call that a combined immune deficiency. And we say combined because, again, those helper T cells will help the B cells to tell them what to do. So in many times, if you have a significant enough problem in your T cells, that can also lead to problems in the antibody. And so hence the name combined immune deficiency. Again, we talked about T cells being really important for bacterial and viral infections, but combined immune deficiencies can also lead to what's called opportunistic infections. So these are infections by organisms or bugs that typically wouldn't cause people problems. So again, we live in environments where there's lots of organisms all around us. And most of the time, we're not sick with infection because our immune systems can handle it. There are certain organisms that do tend to be more common if your T cells don't work well. And one example would be fungal type infections. So Candida, so having recurrent invasive fungal infections, or a type of pneumonia caused by pneumocystis jirovecii, or PJP, is also a type of opportunistic infection that you can see in individuals with T cell problems. So some examples of combined immune deficiencies include severe combined immune deficiencies, and then we have other combined immune deficiencies that may not be as severe. So for example, CD40 ligand deficiency, or sometimes called hyper IgM syndrome. And then we have this other category of immune dysregulation. So these are disorders where you see, again, more inflammation or autoimmunity, and you may not have a significant infection presentation. And so I mentioned that the immune system, one of its jobs is to regulate itself. So you can imagine when it's fighting an infection, it needs to be able to stop fighting the infection when the infection is cleared. And so it needs to have ways to stop the inflammation and calm down that inflammation. If it doesn't have great ways of doing that, then the inflammation can go on. Or again, if the immune system doesn't have a great way of monitoring and regulating its cells to stop them from misbehaving, you can have cells that go rogue and cause autoimmunity or malignancy. So the presentation for these can vary, but you typically will have lots of autoimmunity, and you typically see autoimmunity or inflammation involving multiple systems. So you can have autoimmune low blood counts with autoimmune inflammatory bowel disease and arthritis, for example. So some examples of disorders of immune dysregulation can include X-linked lymphoproliferative disease, or conditions that lead to hemophagocytic lymphohistiocytosis, mouthful to say, or regulatory T cell defects, because again, those regulatory T cells are kind of the police and that can lead to a syndrome that's called IPEX. So we've gone through a brief overview of primary immune deficiencies, and hopefully I've been able to show you that it is a group of disorders that's caused by problems in immune function or immune development that's inherent to those cells or proteins, often inherited with an associated gene that's known to cause that. And many of these individuals who have primary immune deficiencies do have an increased risk of infection. The type of infection often depends on which part of the immune system isn't working well. And I hopefully have shown you too that there's a wide range of presentation as well as a range of age of diagnosis. So again, primary immune deficiency or inborn errors of immunity can be diagnosed at any age. We do hope that increased awareness and increased access to specialists and diagnostic tools will hopefully improve the time to diagnosis and to treatment. So I will end there, and I am happy to take questions.
Thank you so much, V. I learned so much. Oh, my cat is joining us for the questions. Please enter your questions in the chat. We've had some come through while you were talking, so I will start with some questions that we've had. They run from very wide to quite specific. So I think we'll start from very general. What causes an immune deficiency? So I think we'll start there and
Yeah.
see if you want to dig that one down, and then we'll continue with the Q&A.
So a lot of the times with primary immune deficiencies, it's a change in a gene that can cause the immune deficiency. So again, genes in the immune system can lead to production of proteins or cells that lead to, again, those different types of cells in the immune system or different proteins. Sometimes, again, there can be a change in a gene that makes that gene not work well. And so then it doesn't produce protein that is needed to make the immune cell develop well or function well. Sometimes that change in the gene is inherited from a parent or two parents, depending on the type of inheritance. And sometimes that change can be a new random change in the individual that's not inherited from either parent as well. So we believe that many of these primary immune deficiencies or inborn errors of immunity are caused by a change in a gene that's important for the immune system to develop or function.
Thanks so much. Actually, I'm going to lead into the next question because somebody said, if I've been diagnosed with CVID, does that mean I have an inborn error of immunity? They've been saying that primary immune deficiency all along. So I'll let you say that.
Yes. So again, it's a little bit of semantics between the term primary immune deficiency and inborn error of immunity. A lot of people use them interchangeably, or again, some people are quite strict about saying that an inborn error of immunity is an identified genetic cause, where we do know that many patients with common variable immune deficiency may not yet have a genetic cause that's identified for it. It doesn't mean that we won't ever get there, but there are many patients, again, who have lots of genetic testing done to try to identify an underlying cause, and we may not have found it just yet. But CV is still considered an inborn error of immunity because it's still a problem with the immune system in being able to create good antibodies that can help fight off infections.
Thanks. Someone did email us in saying, why would some people with primary immune deficiency or PR not present with a fever? So I know that wasn't in your talk, but I think they're wondering why they wouldn't present with a fever.
So there can be different components to that. We do know that there are some immune deficiencies. Again, I talked a lot about inborn errors of immunity or immune deficiencies that can have lots of inflammation. And we do know that there are some where the immune deficiency itself doesn't actually create a lot of inflammation. And so some individuals, depending on which one, may not mount a great fever and may not have lots of redness or inflammation around the site of infection as well. It doesn't mean that they don't have an infection that's severe, but sometimes that can make it more challenging for clinicians to recognize how sick they are because they're not mounting as great an inflammation response.
I think that's something we encounter a lot. People say they go to the emergency room and they don't have a fever and it's dismissed, but they do have an infection. So
Yeah.
that's interesting to hear. I did not know that. So that is interesting. Thanks. And we have another question. If I have a PI and an autoimmune disorder, does that mean I have an immune dysregulation?
So, probably. And again, immune dysregulation primarily refers to the immune system, again, not being very well regulated. I hate to use the word regulate and dysregulation, but again, it's not doing as great job of policing and controlling itself. There are groups of conditions that fall under immune dysregulation disorders, which is a different type of description. But immune dysregulation itself often refers to autoimmunity or that propensity for increased risk of malignancy, for example. So, certainly having a primary immune deficiency, many of them have a risk of immune dysregulation.
We have a few questions in the chat. Kim, I'll get to yours in a minute, but first we're going to go. Someone has asked, would CRMO be an autoinflammatory disease, IEI?
CRMO typically, I believe, is categorized as autoinflammatory, primarily managed by the rheumatologist, although again, sometimes that can vary from center to center.
And thanks. I hope that answers your question. And then Wendy is asking, do vaccines work for those with immunodeficiency? So I know we've done a few vaccine webinars and vaccine
Yeah.
sessions. So I don't know if you want to say just a couple words about vaccines. That would be great.
It depends on the immune deficiency because, again, not all immune deficiencies cause problems with the B cells or antibodies. And so, if your immune deficiency is, for example, one that involves complement deficiency, we often would recommend extra vaccines to help create some more protection. Or again, if your immune system problem involves the neutrophils or the phagocytes, then the vaccine part or the antibody part would still work as well. And we would still recommend many of the routine childhood vaccines. Additionally, depending on the severity of antibody deficiency, some vaccines may still provide some benefit. And it's always weighing the risk and benefits of vaccines. So, again, for certain vaccines, if you can get some immune response, that may be better than not having the vaccine and not having any kind of immune response as well. So even if your response isn't predicted to be as fantastic as someone else's response, it may still be helpful to provide that extra kind of protection as well. So it really depends on the underlying immune system problem as well as which vaccine. So that's often, again, really great discussion with your clinician or your immunologist around your specific scenario.
Thank you. That's actually a wonderful answer, and I think that's really important. We will be having a vaccine update webinar in September for those who are interested. And Kim has asked, can those with primary immune deficiency donate blood?
It's a good question. Again, I don't know the Canadian Blood Services specific requirements. So, for example, if you're donating blood for red blood cells, depending on your immune deficiency, many times the red blood cells aren't affected, but I don't know the specific criteria for that. And I would have to defer to the Canadian Blood Services or what their indications are.
I do know that if you're on a plasma protein product or you're not eligible, but look at the website. They are always looking for donors. So if you are eligible, you pass the criteria list, please do consider donating blood or plasma, but you do have to look to see if you are eligible. I'm not certain either. And we have another question of where do we stand for treatments other than IVIG and SCIG? So I think that's a question. What are their treatments available for other primary immune deficiency or inborn errors of immunity?
Yeah. So the treatments also depend on which arm of the immune system is involved or what type of immunodeficiency it is. So again, IVIG or subcutaneous immune globulin was mentioned, and that's often a treatment of choice when you have an antibody deficiency. So it's kind of if your immune system can't make great antibodies, then the next best thing that we can do is to provide those antibodies in an immune globulin infusion, either intravenously or subcutaneously. But there are other treatment options that are available depending on your underlying immune deficiency. So sometimes that might involve taking antibiotics or antifungal medications as prevention or what we call prophylaxis at lower doses to try to prevent certain infections. As I mentioned, sometimes vaccinations can also help. And then there can be some very specific treatments, again, for certain types of immune deficiencies, such as hematopoietic stem cell transplant, or what sometimes is called bone marrow transplant, or gene therapy. But again, these are for very specific types of conditions.
Thank you, V. We have one last question, or we have time for two if there's another one, but we have one more. Are newborns being tested now for immune deficiency? And if not, at what age should one be tested? And I think you're the perfect person to ask that. So I'll let you answer.
So, in most regions of Canada, there is newborn screening that's done for a particular type of immune deficiency that's called severe combined immunodeficiency. That is really the only primary immune deficiency that's currently being screened in Canada for newborns, although there may be others coming down the pipeline as well. And there are some, again, combined immune deficiencies that are included in this newborn screening for SCIDs that behave like SCIDs as well. We do hope, and probably in the future, there will be expansion. And there are other areas of the world where different additional immune deficiencies are being screened for as well. But again, not all primary immune deficiencies are screened at the newborn age. I would say when people should get tested really just depends on the suspicion. So, certainly, if there's a family history of someone in the family who has a diagnosis of primary immune deficiency, I think it's important to speak with your doctor about what the risk is for you or your child of having that, and then being screened or tested as needed for that. And then, certainly, if there are concerns clinically that you're manifesting some of those infections, autoimmunity, or inflammation, it certainly would be worth having a chat with a clinician around these concerns. And then again, depending on that, they can decide if additional testing or seeing a specialist would be needed.
Thank you so much, V, and thank you to all of you as well. I'm just going to share my screen again. Thank you all for attending. It's been, I think, such a wonderful session, and thank you to V. I learned so much during this session, so I hope everybody joining us has learned a lot as well. Our next webinar is June 1st on autoimmunity and immune deficiency. I hope you all join. Please, if you have any more questions for us or for V, please email us. Really just love being able to do events like this and have people join, and he's been wonderful. So thank you so much, and I hope you all have a lovely evening. Thanks, everybody.
Thank you.